Good afternoon, Dr. Doherty. Would you please introduce yourself and tell us what you do at VIVA?
Sure. My name is Don Doherty. I'm an interventional physician, interventional radiology, and a vascular specialist here in Richmond at Virginia Interventional Vascular Associates.
What types of procedures do you perform at VIVA Richmond?
Thank you for asking. We don't get to rewind this, right? Like, this is just like going out on the labs.
Yep.
All right. Well, we do a wide variety of procedures, and ultimately, you know, we try to solve problems for patients in the easiest manner. Interventional radiologists, our entire specialty is using pictures, whether it's ultrasound, MRI, or CT, to find problems inside people and fix them. Different examples would be fixing varicose veins for patients, but with using ultrasound to identify the veins. We may treat cancers in patients using CT or X-ray to find tumors and treat them. Or we can use angiography, take pictures of blood vessels and use those pictures to then go in and open up or even close down blood vessels depending on what needs to happen.
So today we're going to learn a little bit more about varicose veins. And what is it about this particular condition that appeals to you, and why does it appeal to you?
You know, varicose veins, I like treating them because many patients don't realize, they seem like a simple problem, right? You just have big lumpy veins on your legs. But they can cause bigger problems for patients, whether it's like pain, like heaviness, maybe they avoid exercising, sometimes they avoid just showing their legs because they don't like how they look. Or, you know, many patients have cramps at night or pain in their legs at night, and they just don't have a reason for it, or they don't understand that these varicose veins can cause that. So when you get a patient in and you can explain it to them, and then treat them and fix a problem that they didn't realize they had and didn't realize how it connected, it's very satisfying.
Is there one particular patient population that might be prone to varicose veins, and who would that be?
Well, I mean, I think we treat patients, you know, across the entire population, but, you know, in particular, women, mothers, people who've had children, they've carried children, maybe they had leg swelling when they were pregnant. A lot of times they'll have varicose veins or vein reflux. People who stand a lot for a living, they tend to have varicose veins. Maybe you work in a warehouse or you're a waitress or waiter. Physicians have a lot of varicose veins. Nurses are standing all the time. I can remember my mother would wear compression hose when she worked as a nurse, and now we're fixing varicose veins for nurses, so it sort of comes around a little bit.
Beside the obvious visual knowing what a varicose vein is in the leg, how do you find out that a patient has varicose veins, beside them sharing some of the pain in a situation?
Sure. You know, when patients come into us, we do a good history and physical exam. And many times you can figure out they have a vein problem just talking to them. They'll say their legs hurt at the end of the day, or they get cramps at night, or their spouse says they kick them at night because their legs are jerking. That's one way. Now, when they come into the office, then we generally diagnose them with ultrasound. We'll arrange for them to have a very detailed vascular ultrasound in our lab with our registered techs, who can then look and make sure certain veins in the legs are open as appropriate. They'll look at the direction of flow, and they'll identify any veins that are running backwards or not running appropriately that may be leading to the problems the client or patient's having.
What's the next step then once you diagnose this?
Well, the first step is helping the patient get into conservative therapy. That's really driven by our insurance companies, because they want to know that you've put the time in to figure things out. And for those patients, they usually wear compression stockings for 6 to 12 months. At that point, then, we have a variety of treatments that we can provide. We do vein ablations, where we can heat the vein and cause it to close down. We may use foams to irritate the veins and cause them to close down. For people who may have bigger veins or harder veins, we can do microphlebectomies, where we go in and take just little bits of the vein out through the skin, through just a tiny nick in the skin. And then one of the things that I'm excited about to introduce in Richmond is our vascular glue, the venous seal procedure, where instead of using heat, instead of 5 or 6 needle sticks, we can go inside the vein with a little tiny catheter and put little micro droplets of glue in and hold the vein shut. Patients love it. It works great, and we're very happy to have it available to us.
Can I just ask a question for clarification? You mentioned the compression stockings. What's the actual time frame? Is it 6 months or is it 6 weeks?
So most insurance companies want you to wear stockings for at least 6 weeks.
Okay.
In general, a lot of patients come in having tried stockings, and so we can use that to satisfy the requirement. We do have a couple insurance companies that require 12 weeks,
Okay.
which isn't a lot of fun for the patients, but we do have to meet their insurance requirements.
I just wanted to make sure because you had mentioned that it was months, and I thought it might be weeks. So
Thank you very much. It's back 20 years ago when we started this, we could see a patient and treat them the next week, but that's not possible anymore, unfortunately.
You had mentioned the new treatment with the glue. What else has changed in treatment for varicose veins in your tenure as a physician? What have you seen?
When I first started as a physician, when I was in training, if you were going to treat varicose veins, the patient was admitted to the hospital. They'd stay in the hospital overnight. Their legs would be wrapped, and it was a pretty miserable treatment, unfortunately, for patients. We had many patients. I've had many patients in my practice who maybe 30 years ago had the old way of treatment and never went back for the second leg. They just refused. And then when we treat them with the newer, less invasive, very, very fast treatments, they're amazed and they're a little upset that they didn't have this back then. And so I think that the trend toward very minimally invasive, very highly targeted treatments to really just treat only the vein and minimize bruising and swelling and recovery has been very satisfying for me over my career.
Are there any types of things that someone who might be looking at their legs could do maybe to help prevent something like a varicose vein happening? Any lifestyle changes that they might want to consider?
That's hard. Varicose veins and the likelihood to get varicose veins are driven by our genetics for a large part. So they're hard to avoid. They're driven by genetics, they're driven by the jobs we have, standing a lot. They're driven by pregnancies. When we've had multiple pregnancies, we're more prone to getting varicose veins. But that being said, for people who stand a lot in their jobs or may have a genetic or familial possibility of having veins, starting compression stockings, wearing compression socks even, are very helpful to help at least delay the onset of these veins.
Okay. You had mentioned insurances before. I thought varicose veins were basically just a cosmetic thing, but it's obviously something more. Would you like to explain a little bit more about that?
Varicose veins are a medical problem, and patients come into us with medical issues and medical complaints. Sure, a tiny spider vein may just be a cosmetic complaint, and that's how a lot of our patients come in. However, once you talk to them and really get their history and figure out, you can figure out what other problems they're having. Many patients, they may focus on the cosmetic problem, but then they don't realize that the leg pain they've had for 2 years, or the calf cramping they have at night, or the swelling, the little ankle sock swelling they may get, are all related to the varicose veins. And those are real, true medical issues and medical problems, and they deserve treatment.
You mentioned the spider veins before. Can you explain a little bit more about what's the difference between a true spider vein and a varicose vein?
They're really all the same thing. However, we tend to group them by sizes. The spider veins, those tiny little fine red lines around the ankles, maybe on the thighs, those tend to be called spider veins. As they get larger, we'll call them reticular veins. Maybe they get to the size of a toothpick or something like that. And once they start getting bigger and larger, maybe the size of a pencil or a rigatoni or something like that, then we start calling them varicose veins. But they all relate, all those words relate to veins that are too big for where they are.
So if someone sees a spider vein, let's say on their ankle or down near their thigh or their calf, should they be concerned, and should they possibly come to see you at that point?
You know, I think it's worth a consultation. I think it's worth coming in, talking to us, and seeing, you know, seeing where the vein is coming from. Spider veins are not normal. They're not. We aren't born with them. We develop them over time. And for me, they're a sign of the fact that maybe there's too much vein pressure, or the veins are running backwards in a certain area of the leg. And I think that is a very appropriate and acceptable reason to come in for consultation.
One of the things that you had mentioned was the compression stockings is the conservative treatment. It's about 90 degrees out there. So if I'm sitting here saying, okay, I'm seeing some of these things in my legs and I'm noticing them, what would you suggest that I do right now, being sort of in the summer time frame?
You know, if it was up to me, I would move a little faster with the treatment than insurance companies allow us to. However, it's always worth coming in for a consultation. Come in, figure out where the problem is, and then when the temperature is more appropriate and it's more fun wearing thick compression stockings, then you can start wearing them and start the clock on treatment. The challenge we get into, the challenge I've gotten into having done this for a while, is patients know they need to wear stockings, they don't want to wear the stockings, which I totally get, having worn stockings before. But what will happen in my practice is, in most vein practice, is that if you start coming in, you start wearing your stockings in September, you're not finishing your stocking trials and stocking requirements until December. And you're with a whole bunch of other people who want to get treated by the end of the year. So it's always worth coming in earlier, and then you can have a plan to get on the books and get evaluated and treated.
Are the compression stockings a little bit more, shall we say, appropriate these days than some of the old-fashioned ones that people might know? Maybe some better colors?
You know, compression stockings are compression stockings. They're a little tight, they're a little thick, because they need that to do their job. But they come in different colors, they come in different lengths. You know, if you go to a running store here in town, they have knee-high compression stockings. You know, they call them recovery tights, but they're just compression stockings. So I think there's a style for pretty much everyone out there.
Do you recommend someone being professionally fitted for compression stockings to make sure that they're...
Yeah, you need to be professionally fitted. You know, it isn't a one-size-fits-all. There are about 7, 8, 9 different sizes and different lengths, and you want something that fits you. Patients who hate their stockings, generally they're in the wrong size. They're either too tight or they're too long. And if you get them professionally fitted, they're going to stay on better, they're going to fit better, and you're more likely to be able to complete the treatment successfully.
Is there anything else that you'd like to add about varicose veins, about compression stockings, that maybe we can share with our audience here today?
You know, it's for me, it's not just a cosmetic issue. It's not just a vanity issue. And a lot of people over the years, they resist being seen by a physician for varicose veins, either because they don't like them to be seen, or they just feel it's maybe beneath them to do something for their appearance. But it really is, it's a sign of an additional medical problem that is causing not just it's a cosmetic issue, but you know, it will have associated swelling or pain, discomfort, some other effect in your life, and it's worth having them taken care of, at least evaluated and figure out what's appropriate for you.
Okay. Dr. Doherty, thank you very much. And you can reach us here at VIVA at 486-4625. Thank you.
Thank you for having me.